In a contemporary study, Nair clinically resected 16 mesial roots from endodontically treated lower molars and demonstrated what other scientists had suspected for decades, that gutta percha was most often surrounded by a sea of almost every conceivable form of living and necrotic material, including microbiota, ranging from plant cells to species of bacteria. This failure to clean finding has been affirmed in more recent studies by Guterres and Klin, who each independently demonstrated that positive pressure endodontic irrigation, even when combined with various agitation techniques, including one method that combined direct intracanal irrigant delivery with ultrasonic activation, all failed to adequately cleanse the complexities of the critical apical third, especially in the last millimeter. However, in a breakthrough study using the EndoVac system of apical negative pressure, Tay and Pashley demonstrated it is possible to eradicate virtually all debris from the challenging apical area, thus facilitating complete obturation and thereby denying the space needed for biofilm colonies to reform. So, why is apical negative pressure able to clean these areas so much better than positive pressure? First, studies by Senia, Chow, Boutsiokis, and most recently Tay have proven that positive pressure irrigation creates a dead water zone when the canal termination is closed, as shown here. However, unlike positive pressure, apical negative pressure draws abundant irrigant to the canal's termination, first with the macrocannula, then with the microcannula. This continuous irrigant exchange aspirates tissue, instrumentation remnants, microbiota, and even separated instruments into the office HIVAC. Secondly, although science has not determined the exact cause of massive sodium hypochlorite apical extrusions, intracanal positive pressure is the common denominator. To demonstrate this point, a simulated glass root canal with an open termination of 350 microns and tapered at 4% in the apical area easily permits a 30-gauge needle to pass through the apical constriction. Accordingly, it would be impossible to bind the needle anywhere in the canal, yet when the tip of the side-vented needle is placed about 6 millimeters from the canal's termination and irrigant is delivered at a normal clinical rate, more irrigant can be extruded apically than coronally. This could answer the question as to why serious sodium hypochlorite accidents can be so severe and can happen without warning. Furthermore, recent studies have demonstrated that a root canal roughly shaped to the dimensions of this glass model can produce apical pressures exceeding 100 millimeters of mercury or normal arterial pressure. Fortunately, when apical negative pressure is used to draw the irrigant to the apex, it moves safely and abundantly to the canal's termination and no further, even when the canal termination is open, as demonstrated here using the same model used with the side-vented needle. This safety characteristic has been documented in vitro by Desai and Mitchell and clinically by Gondam. As an important side note, this case, reported by Pelka in 2008, describes a woman who suffered permanent motor and sensory nerve damage due to a sodium hypochlorite incident. He concludes the case history by emphasizing the need to inform the patient of the dangers of sodium hypochlorite. Following Pelka's report, Rochelle and Abota Returni published a strong legal opinion describing the requirement to inform the patient of the dangers of positive pressure endodontic irrigation, and the fact that several studies have recognized the safety of the EndoVac system. This is a must-read opinion that can be found with Google by typing informed consent hypochlorite and selecting has the doctor's duty to warn.